At BID Milton, we have several options for weight loss surgery. First one is traditionally was the lap band, and then next one is the sleeve gastrectomy, which has not only caught on, but it actually has become the nationally number one in terms of the amount of patients that are getting that. Then you have the trusted and true the Roux-en-Y gastric bypass, which is still quite a bit of the procedure that are performed nationally. I kind of counsel the patient through the different procedures. I tell them what the procedures are, and I cover risks, benefits, and alternatives being the other procedures, and they can make their minds. As long as it's medically fit for them, then they make that decision. For the gastric bypass, what we do is we are constructing a small pouch of stomach. So we basically divide the stomach into two portions. One top portion, which actually is about the size of an egg, and the rest of the stomach is completely separated from that. Then we bring up a piece of the intestine that we measure out, and we connect to that pouch of the stomach. So what ends up happening is that you have the food would go from the esophagus into that small pouch of stomach, where you get your restriction, so it's a small component of the stomach, and that's connected to the small intestine. So the food will go straight to the small intestine without passing through through the larger part of the stomach that's right after that. So this is why it's a gastric bypass. You reconnect the intestines downstream from that to make sure that the digestive enzymes join, and this is where digestion can happen. So it's both restrictive and malabsorptive, because it's bypassing the areas where you would usually absorb the food. The amount of weight loss that you expect with the bypass is about 3/4 of your extra weight, so it's more than what you would get with a sleeve. It's also been shown that it has slightly superior results in terms of sugar control and diabetes, and it has shown long-term success in the patients. The bypass has been a procedure that's been performed since the 60s. It's been perfected over a long period of time, and it's really well established. So this is why they call it the gold standard of all procedures. The sleeve gastrectomy is a procedure where you're removing a portion of the stomach. So you're converting the stomach into a tube-looking structure. That restricts the amount of food that you can have in your stomach, but also, more importantly, as we later learned, it's not just about restricting the size of the stomach, it's more about the effect on the hormones. What we do is we remove about 60-70% of the stomach out and along the outer edge of the stomach. So you end up with a sleeve-looking structure, tubular structure, that is going to be restricting the amount of food that the patient can take. We cut the stomach and we examine it at the end, make sure there's no leakage, and there's tiny little staples that hold the edges together. It will also affect the hormones, which is the really very powerful part about this, is that there's a hormone called ghrelin. There's a significant decrease in that, and it decreases the amount of hunger pangs that you get between meals. So the patients need to remind themselves of actually eating. The lap band has gradually fallen out of favor. The reasons are because the lap band was initially devised when we were just in the infancy of laparoscopy, and we really didn't know how to operate as well laparoscopically at the time. And then what happened is that as we got more proficient, we started discovering other procedures. The lap band itself is low risk, so that's still the attractive feature. So it's a low risk procedure, very simple technically. It doesn't take a long time in the operating room, and it's still, I think, in some cases, maybe a good procedure in selected patients. Like the patients that would not qualify for other procedures, the band may be an option. The other thing is that if a patient is too risky for the other procedures, a band may be a good option as well. So this is the times when I would perform the band. Otherwise, if the patient is really insistent on the band as such, as long as they don't have any exclusion criteria, I think it's still a valid option in some cases. And then there is the revision procedures, which is essentially procedures that are done on patients that have had prior procedures, and they had either complications, failure of weight loss, or they just need to have some procedures reversed or adjusted for that. And these would be revisional procedures.